Hello and welcome to our professional webinar series. I am Cynthia Milburn, CEO of Epilepsy South Central Ontario. We are the community agency for a big area of Southern Ontario, and we provide counseling and support for people living with epilepsy, their families, and caregivers. We do this through our programs and services, all of which you can find on our website, which will be posted. We are providing counseling and support during COVID-19 quarantine, and if you call our office, do leave a message on any individual's extension and your call will be returned as quickly as we can. Today, we are very privileged to be hearing from Dr. Elizabeth Donner, who will address the very sensitive topic of sudden, unexplained, and unexpected death in epilepsy, known as SUDEP. We refer to this as the elephant in the room because many people fear this, think about it, but don't talk about it. However, knowledge is power, and the more you know, the better you can manage your own epilepsy and/or your loved one's epilepsy. Dr. Elizabeth Donner is the director of the Comprehensive Epilepsy Program at the Hospital for Sick Children in Toronto, Michael Bahen Chair in Epilepsy Research, and Associate Professor in the Faculty of Medicine at the University of Toronto. Dr. Donner has received peer-reviewed funding to examine the risks and the risk factors for sudden death in epilepsy and the efficacy of dietary therapies for drug-resistant epilepsy. She is co-founder of SUDEP Aware and a non-profit organization which promotes knowledge and understanding of sudden, unexplained, and unexpected death in epilepsy. She has held leadership positions, including Secretary-Treasurer of the Canadian League Against Epilepsy, Chair of the Canadian Paediatric Epilepsy Network, and Vice President of the Board of Epilepsy Toronto, and Chair of the American Epilepsy Society's SUDEP Task Force. Dr. Donner is a member of the steering committee for the Canadian Paediatric Surveillance Program and is currently co-chair of Partners Against Mortality in Epilepsy and co-lead of ECHO Ontario Epilepsy Across the Lifespan. Dr. Donner, welcome and thank you for joining us today to present on this very important subject.
Thanks, Cynthia. It's good to be here. Sorry, that's the classic, don't forget to unmute. It's good to be here and I appreciate you inviting me to talk about this today. It's funny times, but I'm happy to welcome everybody into my living room to talk about this topic of which I am quite passionate. I'll just start my slides and then we can get to it. So, this is what I'm talking about today. So I'm talking about understanding sudden unexpected death in epilepsy. I've got your faces right in front of me. I'm just going to put that somewhere off to the side. So first things first, this is a pretty difficult topic. And I think it's important to acknowledge that right off the bat. It's a hard thing for me to talk to people about even under normal circumstances. And I recognize right now, a lot of people are isolated, a lot of people are alone, and it's easy to have thoughts ruminating in our heads. So I am doing it anyways, but I just wanted to kind of call that out. And the reason I'm doing it anyways is because I think the risk of, serious consequences of epilepsy and the risk of dying due to a seizure or due to epilepsy is really like the elephant in the room a lot of the time. Sometimes I feel my patients come and they want to ask, but they're scared to ask. And so I think other people know it's the elephant in the room too. And for that reason, I'm one of the kind of champions about talking about SUDEP with people. And in fact, we know that people with epilepsy want to know more about their risk of dying due to epilepsy. So one study found that up to 60% of adults living with epilepsy and almost all of the caregivers of people with epilepsy said they were worried that the person with epilepsy may die of a seizure or die related to their epilepsy. An interesting study that looked at Google searches for the term epilepsy SUDEP found that there was a 5,000% increase in Google searches for epilepsy SUDEP from 2004 to 2013 when that study was done. I imagine in the year 2020, it's even higher now. One study of parents of children with epilepsy living in the United Kingdom found that 91% of those parents wanted to know more about SUDEP. And a study that I was involved with where we questioned people who had actually lost a loved one to SUDEP, 72% of those people commented that they wished that it had been discussed with them. So with that in mind, I'm just prepared about 20-25 slides today just to go through some kind of high-level stuff about SUDEP, and then hopefully leave lots of time for questions, because I know people have a lot of questions about these topics. And what I'm going to talk about pretty briefly is just to describe the risk of early death in people with epilepsy, to review risk factors for early death, to outline some strategies for risk reduction, and then, like I mentioned, to answer your questions and address your concerns. So we know that people with epilepsy are about 2 to 3 times more likely to have an early death compared to people without epilepsy. That risk is actually even a bit higher in children for 2 reasons. First, children who are born with very significant neurological problems have other reasons that they have an increased risk of death. And also, children in general have low rates of death. So anytime we see deaths in children, it's, you know, it pushes it to higher than what we see where kids don't usually die. Thank goodness for that. Some of the factors that increase the risk of death, and that's what I'm calling predictors of mortality in people with epilepsy, are having ongoing seizures. So not having your epilepsy go away or not having it be controlled with medication. And also if the epilepsy is due to a known brain disease or brain disorder, something like a structural brain disease, or where there's actually a problem with the structure of the brain, like a lesion in the brain, or a degenerative or metabolic disorder that's causing the epilepsy. And also we know that not following recommended treatments for seizures increases the risk of death, not just due to SUDEP, but just in general. And when we think about why a person with epilepsy might have an early death, well, of course, deaths in epilepsy, I mean, these could be unrelated to, in people with epilepsy, could be completely unrelated to the epilepsy at all. People with epilepsy obviously still die of things like heart disease and cancer, diabetes. Deaths could be related to the cause of the epilepsy. Like an example of this would be a person with a brain tumor where the brain tumor causes the epilepsy, and it also results in an early death. There's also what we call unnatural deaths. And this is things like accidents, traumas, suicides, drownings. And then there's deaths due to epilepsy itself. Before I move on to that, I just want to talk about this unnatural deaths thing a bit, because I think this is really important and something that maybe we forget to talk about a lot because we're talking a lot about SUDEP. And there was a very good quality study that was published under 2 years ago, and it's out of the United Kingdom, where they studied thousands and thousands of people with epilepsy, and they compared them to people without epilepsy. And they looked at risks of death due to these like unnatural causes. So that's things like suicide, trauma, motor vehicle accidents, even homicide, drowning. And they found that people with epilepsy are at a significantly increased risk, sometimes 2, 3, or 4 times the increased risk compared to people without epilepsy. And what that study highlights for me, particularly with regards to the suicides, is really that we need to ensure good mental health screening. And that means asking people with epilepsy about their mental health and good mental health support and treatment for people with epilepsy. And so if you're a person living with epilepsy, I certainly encourage you, if your doctor's not doing this with you, for you to push your doctor to talk about these issues with you if you're able. We ourselves conducted a study looking at deaths within the province of Ontario over a 2-year period. And we found that people with epilepsy were at a 10 times increased risk of drowning compared to people without epilepsy. And maybe that's not surprising because you've probably heard that people with epilepsy need to be very careful around water, when they take a bath, if they're swimming, because of the risk of having a seizure while they're in the water and consequently dying and drowning. In our study, 44% of the deaths occurred in the bathtub. And most of those people were otherwise well people living with epilepsy who drowned in the bathtub. So again, this really highlights the need for really strong counseling regarding water safety in people living with epilepsy. So going back to deaths due to epilepsy itself, these can be a direct consequence of a seizure. So things like having a car accident because you had a seizure while driving, or drowning, deaths due to status epilepticus, and that's when seizures are prolonged and don't stop. And what we're here to talk about today, which is sudden unexpected death in epilepsy. And I've written there sudden unexplained / unexpected death because they used to call it unexplained and then they changed it to unexpected. And I just want people to know that it's the same thing. And the short form we use for that is SUDEP. So what is SUDEP? Well, this is a list of 7 criteria, and it's more wordy than it has to be. Really, SUDEP is when a person has epilepsy and they die unexpectedly and suddenly, and it wasn't due to one of those accidental things that I mentioned before, like trauma or drowning, and it wasn't due to status epilepticus or prolonged uncontrolled seizures. It's important to recognize that the death could have been witnessed, but a lot of SUDEPs are unwitnessed. And it's not always the case that a seizure occurs immediately before death. And I know of quite a few cases where it's evident that a seizure did not occur before death. And the last criteria for a SUDEP death to be kind of properly classified as SUDEP is that a post-mortem examination, which is the same thing as an autopsy, does not find a cause of death on autopsy. Now, there are a lot of deaths where an autopsy is not performed, and that's complicated about when an autopsy is performed and when it isn't. So when we do our research on SUDEP, we still study deaths in which an autopsy is not performed, and we use all these other criteria, and we kind of make a decision about whether we would call that as SUDEP or not. So a few years ago, about 4 years ago now, I was involved with a project with the American Academy of Neurology and the American Epilepsy Society, and those are the 2 big groups. They're based in the US, but they're really international organizations, lots of Canadians and Europeans and Asian from all over the world involved with both of those organizations. And those are the organizations of people working professionally in the area of neurology and epilepsy. And they got together and decided that we needed a practice guideline, which is a document that helps people treating people with epilepsy, most of the time physicians, but it could also be useful to nurse practitioners, registered nurses, other healthcare practitioners. It helps them with guidance around how to treat the condition of SUDEP when it comes to working with people with epilepsy. And so we got together to develop this guideline, and we asked 2 kind of specific questions. The first was, what is the incidence rate of SUDEP in different epilepsy populations? And the second was, are there specific risk factors for SUDEP? So since a lot of the, this would be kind of like a go-to document for doctors who are treating people with epilepsy. And so I think it's a good starting point for us to look at these questions and talk about them. So first, incidence. So incidence means how common is it, right? And the way we look at incidence in something like SUDEP is we talk about number of cases of SUDEP, so number of deaths per 1,000 patient years. So a patient year is one person living for 1 year with the disease. So in this case, epilepsy. So 1,000 patient years is if I follow 1,000 people, if I watch 1,000 people with epilepsy for 1 year, how many will die? And what they found here was that the overall incidence was 0.6. Okay, so about 1 person per year, a little less than 1 person per year out of 1,000 people will die of SUDEP. Interestingly, when we, and the way we kind of came up with this stuff is we reviewed all the studies that have been done in the past. And interestingly, when we reviewed all the past studies, they actually found that the rates were quite a bit lower in childhood and higher in adulthood. Okay, and that's kind of where it comes out to this 0.6. So adults, it was about 1 in 1,000 per year, and kids, it was really almost 10 times less than that, 0.2 per 1,000 per year. But one of the things that happened was some of us then kind of didn't really believe that. We felt that what that reflected was the fact that the studies that had looked at rates of SUDEP in children had actually been underestimates, because it was hard to find those cases for lots of complicated reasons about why it's hard to label kids with SUDEP sometimes based on the way the system works. So some of us felt that it was probably not accurate to say that the rates were so much lower in children. So there are two studies that address this. One is the study that we did in my lab, and that was with Ann Keller, listed here, published in 2018. And the other was done in the lab of Dr. Torbjörn Thompson with Dr. Svensson as the lead author, published in 2017. And interestingly, what we both found, so them in Sweden and us in Ontario, was that actually the rates in under 16-year-olds in Sweden and under 19-year-olds in Ontario are actually 1 per 1,000. So we're actually now able to say pretty conclusively that regardless of age, if you consider all people with epilepsy, 1 person per 1,000 per year will die of SUDEP. Now, we know that there are certain groups that are at increased risk, and that kind of takes me to the next question that I want to assess, which is, it's fine to say it's 1 in 1,000 per year, but who are those at-risk people? How can we identify who's at the most risk of SUDEP? And the reason why it's important to do that is that maybe we're going to come up with some prevention strategies. And maybe some of those prevention strategies are going to be things that we really only want to apply to the most at-risk people. Some prevention strategies can be done by everybody, but some might be irritating or intrusive or awkward, and they might be best delivered only to people who we consider to be at the highest risk. So we can look at different things about SUDEP, about like what we know about SUDEP deaths, to try and figure out what is it that puts some people at risk, or what identifies those who are at higher risk of dying from SUDEP. So first we can look at what we know about the circumstances of death. So in the vast majority of cases, most people are found, if they've died a SUDEP death, dead in bed in the morning. So the deaths occur most often in bed from sleep. Most often people are found in what's called the prone position, which is like a face down position, so lying on their stomach essentially. And usually those deaths are unwitnessed. So usually people are alone at the time when they die. That leads us to believe, does it mean that you're less likely to die if you're not alone? That's not 100% clear, because we know that actually in children, it's much more common for someone to be present when the child dies a SUDEP death, because we know, for those of you who are living with a child with epilepsy, we know that there are many families that either room share or bed share with their children who have seizures through the night. And sometimes even parents have been, or a sibling have been present when a child has died. Most of the time, but not always, there's a seizure before death, as I mentioned earlier. And there's a little bit of a suggestion that some kind of overnight supervision or overnight monitoring might reduce risk. We can talk about that a little bit later. There were lots of studies trying to figure out what is it about the epilepsy or the treatment or the seizures that put people at increased risk. And some of the early studies, and this is a very nice paper by Dale Hestorfer and her team, some of the early studies found that there was an increased risk with frequent, what I've written here, GTC, or generalized tonic-clonic seizures, or really what we think as, they used to call them grand mals, or grand mal seizures, but really what we think of as like the full body shaking seizures or generalized convulsive seizures. So there's an increased risk with frequent full body convulsions and with younger age of epilepsy onset. So you can see I wrote there polytherapy and then I put a big red line through it. The reason I did that is because the early studies actually suggested that the more drugs more medicines people took for their epilepsy, the higher their SUDEP risk. But we now know that that is not true. In this study specifically, when they went back and looked very carefully, you can see the name of the study is very specifically, do anti-epileptic drugs or generalized tonic-clonic seizure frequency increase SUDEP risk at combined analysis? So what they did is they went back and looked at the study that found that the number of drugs you were on increased risk, and they considered the frequency of seizures. So of course, it's not surprising that people who have more seizures are on more medications because the doctor and the patient are trying to figure out how to reduce the seizures, so they keep adding medicines. So if you consider how frequent the seizures are, and then you look at the number of drugs, in fact, there is no increased risk associated with being on a higher number of medications, and there's no increased risk associated with any single medication. And further to that, this really nice study looked at people who were enrolled in clinical trials to check out whether new medicines are useful for treating seizures. And so you might know about those randomized controlled trials that are done by pharmaceutical companies, that the way they're done is people are put on, they're randomized to either receive the new drug or a placebo. And so what they found in this study is they looked at all those trials and they looked at all the people that got the new drug and all the people that got the placebo. And they found that the people that got the new drug had a very much reduced SUDEP risk compared to the people that got placebo. And I'll remind you, placebo means it's no drug. It's just kind of like an empty pill, or what people sometimes call a sugar pill. So what this tells us is that SUDEP rates are lower in people prescribed an effective dose of an extra drug to try and control seizures. So in fact, adding medicines on looks like it actually reduces the rate of SUDEP or the risk of SUDEP when you're using the right drugs. And so, in fact, when we look back at those early studies that suggested that the number of drugs you take increases your risk of SUDEP, we now know that's not true. What we do know is true is that the frequency of generalized tonic-clonic seizures or grand mal or convulsive seizures is the biggest important predictor of SUDEP risk. And so here, unfortunately, this analysis was done with the polytherapy in here, but I just want to show you that, for example, a person who has more than 3 generalized tonic-clonic seizures per year has up to more than 35 times increased risk of having a SUDEP death. And so when we looked with that American Academy of Neurology guideline, we looked at all the papers that had been, all the studies that had been done looking at risk factors for SUDEP. These are the most concerning risk factors that were identified. So having generalized tonic-clonic seizures as opposed to having epilepsy but having some other seizure types. If a person has generalized tonic-clonic seizures, their chance of having SUDEP is 10 times higher. If they have more than 3 generalized tonic-clonic seizures per year, the risk is 15 times higher. And I want to stop on that for a sec, because certainly I know a lot of people with epilepsy, and I know a lot of people who are working really, really hard to try and reduce their seizure frequency. But I also know people who are maybe sometimes feeling content with having maybe 3 or 4 seizures per year. And if they've worked really hard to get to that, and that is the best that they can get to, then I understand that. But I hope that people are not giving up on trying new treatments when they're still having some generalized tonic-clonic seizures, because we can see even just having more than 3 a year really increases the risk of SUDEP a lot. We also know that not being seizure-free for up to 5 years increases the risk of SUDEP. And like I was talking about with the discussion around medications, not adding a medication when patients have seizures that aren't controlled increases the risk 6 times. And now let's talk about this nocturnal supervision, this idea of nocturnal supervision or nocturnal listening device. So, you know, this is the idea of if we use, and by nocturnal listening device, we usually mean like kind of like a baby monitor, like just an auditory baby monitor, or nocturnal supervision. By that, we mean being in the same room with someone during the night. So like room sharing during sleep. There's a couple studies that have shown just a very small risk reduction in cases where people either lived in a group home setting, and so there was someone who was awake through the night checking on all the people that lived in the group home or institutional setting, or in people who shared a room with another, either like a adolescent or a sibling, or with an adult. And so that's why we see just what these numbers mean is just a small reduction in risk associated with either room sharing or using an auditory listening device. So we talked a lot now, or I talked a lot because I'm doing all the talking, but I talked a lot about the risk of seizures associated with being higher in people who have frequent generalized tonic-clonic seizures. And so that leads us to think that maybe SUDEP affects people who are having seizures all the time. I think it's also important to recognize that there are reports of SUDEP in people who have less frequent generalized tonic-clonic seizures, and we don't really understand what that is. And I myself know of cases where kids of teenagers who had been pretty well, who had only really had a handful of seizures in their lifetime, and then so sadly, unfortunately, they died of SUDEP. So we don't quite understand that. This paper is one example of that, of a project that I was involved with through what's called the North American SUDEP Registry, the logo down here, where we actually found that 3 cases of children who had what we usually consider to be a pretty safe epilepsy, called benign childhood of epilepsy with centrotemporal spikes, also known as Rolandic epilepsy. We found 3 kids who had actually died of SUDEP who had that what we usually consider to be a pretty safe type of epilepsy. So trying to understand why those people would have died of SUDEP, we can think that the risk in that case might be related to nocturnal seizures. Children with that type of epilepsy that's written there on the screen, they actually usually have their seizures at night. And oftentimes they're not treated for their epilepsy with an anticonvulsant. So that may also play a role. Finally, it's also possible that people don't know that they're having frequent seizures, because if seizures occur at night and they don't have signs in the morning, and I recognize a lot of people know if they've had a seizure overnight, that they can tell, but sometimes people can't tell. And for sure, there might be factors we don't yet understand. And a lot of us, including those of us working at the North American SUDEP Registry, are trying really hard to understand these things. So at this point, I think I've titled this Expecting the Unexpected. You know, I think we do understand who is at the highest risk. And those are people with earlier onset epilepsy under the age of 16, people with refractory convulsive seizures, refractory meaning we can't get them under control with medication, and probably people who have no nocturnal supervision of any kind. We still don't know, though, among those with frequent generalized tonic-clonic seizures, what really distinguishes when and if they will occur. One of the big questions in my mind and in the minds of other people who study SUDEP is, why is it that I could know a person who has had sometimes hundreds of seizures in their lifetime, that one day where they have that seizure and it results in a SUDEP death? What's different about that day, and what can we do to prevent it? And what predisposes some people who have infrequent seizures to die of SUDEP as well? So those are some unanswered questions, but I think even with that, we can still have a plan for SUDEP risk reduction. And really, the plan for SUDEP risk reduction is to have good epilepsy management and to take care of the person's epilepsy. And while sometimes when I talk to people about this, and I talk to people with epilepsy, but I also talk a lot to doctors who treat people with epilepsy and nurses and nurse practitioners. And I think that they say, well, yes, I'm already working with all my patients on trying to reduce their seizures. We already work on active epilepsy management. But what I want to make sure that people understand is that when they're talking about reducing seizures, following their taking their meds and trying to avoid seizure triggers and all that, that they're actually not just talking about controlling seizures, but they're also talking about reducing the risk of SUDEP and trying to keep themselves safe from that risk of early death. And I think it's really important that people understand that. So my plan for SUDEP risk reduction is really active epilepsy management. And that includes trying to have as few generalized tonic-clonic or convulsive seizures as possible. That remains our utmost, most important treatment goal. Taking medications as prescribed and following the other recommendations from the healthcare team as well. Identifying and avoiding triggers for seizures, I think, is very important. And I know that a lot of people living with epilepsy are able to identify what their triggers are. Using a nocturnal listening device like a baby monitor, I think, is probably a reasonable recommendation at this time, but I recognize it's not always feasible. And sometimes I really feel bad giving that recommendation because I know that not everybody lives with someone who can have a baby monitor in the next room or beside them to allow for that type of monitoring. And finally, it's really, really important that when seizures are not controlled by medication, that we strongly consider other epilepsy treatments when the medications aren't working. And what I mean by that is for people who have drug-resistant epilepsy, which is very clearly defined as when two trials of medication have not worked to stop the seizures, that those people need to be referred to a comprehensive epilepsy center where they can be evaluated to see whether they can have surgery for epilepsy, whether they would benefit from a diet for epilepsy or a vagal nerve stimulator to treat their epilepsy. Because ultimately, if we can reduce the number of seizures people are having, we will reduce the risk of death. And finally, I think really talking about this is the most accessible tool that we have for SUDEP risk reduction, because I want everybody to understand that keeping themselves safe from seizures, doing our best to reduce seizure frequency is our best tool. And unless we talk about it and people know that, we can't expect them to act on it. So I usually end by saying it is time to talk about SUDEP. Finally, I want to say that I know it's stressful to talk about this at the time. That's how I opened my little talk, and that's how I'm closing it. And so the team at Epilepsy South Central Ontario and Cynthia, who's going to be back with me in a few minutes, has informed me here that people can reach out for counseling or support through the website or by telephone. And there's lots of really good information about SUDEP online as well. And I've listed some websites there. I trust all these websites and I think they give good quality information. And I always encourage people to go to recommended websites because we can always find really scary things online that maybe aren't very based in evidence. My very last slide includes some pictures of some beautiful people who I came to know through their families only after they passed. And the beautiful people that are pictured on this slide here come from families that have supported my research and my clinical and my advocacy work. And for that, I'm very grateful. And that wraps up my formal comments. And I'm hoping, Cynthia, that we can open it up and have some discussion and that kind of thing. Oh, Cynthia's muted.
That's me this time. Thank you very much for such a really comprehensive overview, yet understandable. And there's one question: is there any research indicating a similarity between SUDEP and SIDS and that sort of part of the brain?
Yeah,
end up in a prone position. Oh.
That's a great question. Lots of really interesting research. So there are similarities, aren't there, between SUDEP and SIDS because SIDS usually would happen from sleep. And we know that when we I can't say we, it wasn't me, but when there were really successful public health campaigns that convinced people to put their babies to sleep on their back, that we saw a reduction in SIDS rates. And so those are two strong similarities. And so what people have done is they've actually looked in the part of the brain of babies who have died of SIDS, and it's the lower part of the brain known as the brainstem. And what happens in the lower part of the brain there, the brainstem, is actually it controls a lot of the control of breathing and heart rate. So it's a place you might look to see if there's something wrong in someone who died unexpectedly, just seemed to have died out of nowhere, to check what's happening in that part of the brain. And they actually found that some of the chemicals in that part of the brain of babies that died of SIDS are different, that the concentrations are different, or the maturity of that part of the brain is different. And there's some nice science going on looking at similar type of things in the animal models. So in rats and mice who die of SUDEP, we have some genetic models where there are rats and mice with genetic diseases that ends up giving them epilepsy and sudden death. And people are studying very carefully the brainstem of those animals. So people are trying to figure it out.
Oh, great. There's a couple questions here you touched on, you did explain, but I'll just, maybe you want to just recap.
Yeah.
Can SUDEP happen in all types of epilepsy, and are there certain types of epilepsy more or less at risk for SUDEP?
Yeah, that's good. There's a little bit more to expand on that. I mean, for the most part, it happens in people with generalized convulsions, right? The generalized tonic-clonic seizures. That's what I talked about. There are some specific epilepsy syndromes where they're more at risk, and there are some where it seems that people are really at a much smaller risk. So if you don't have generalized tonic-clonic seizures, the risk is quite a bit lower. If there's a type of epilepsy, Cynthia, I know you know about it, but called childhood absence epilepsy, and that's kids who mainly present just with staring spells. Sometimes they can have a full body seizure. I think SUDEP risk is extraordinarily low in those children. And I personally have never heard of a case of SUDEP in a child with childhood absence epilepsy. There are some genetic syndromes where SUDEP appears to be more common. One example of that is Dravet syndrome, which, as you know, Cynthia, is related to a genetic problem with a sodium channel gene. So we have these channels, little pathways in our cells to allow sodium to go, salts to go in and out of our cells. And children who have a mutation in a gene that controls those sodium channels can sometimes have something called Dravet syndrome. And kids with Dravet syndrome do seem to be at an increased risk of SUDEP compared to kids who don't have Dravet syndrome. But actually, we're actually trying to do a study right now to understand that better, and we're collaborating with some people in the US and some people overseas to try and understand that better, because we really need to understand, is that just because kids with Dravet have lots and lots of seizures, or is it something specific about having the sodium channel problem? But it's allowing us as researchers and the people that study SUDEP in the lab and in animals, like I described a few minutes ago, it's allowing them to start thinking about, could it be something with sodium channels? Could it be something with that gene? So there are some groups that are more at risk, and obviously that's a terrible tragedy. The only, can't even call it a silver lining, but is that it helps us to maybe think about how to study this and how to get to the bottom of it.
Wow. Someone's asking, is this a silent seizure? Usually I hear my daughter's seizure. What is the risk factor of SUDEP? Does it mostly happen at night or at any time of the day?
Yeah. So I mentioned that most of the time it happens after a seizure. And most of the time when I'm referring to that, I mean a seizure that you see. But it sounds like the person who wrote that in maybe understands that the seizures we see are when there's a seizure in the brain and it comes out in the body. But sometimes, as we know, you can have a seizure in the brain and it doesn't come out in the body, right? So it's just the brain that is seizing.
Right.
And we don't know most of the time whether that's happened, because the only way you can know if a person's having kind of like what she's calling or he's calling a silent seizure, the only way we know that is if we have an EEG running, right? A brainwave test running. Now, there was a study that's very often quoted, a very high quality study called the Mortimer study, which looked at deaths that had occurred in epilepsy monitoring units. So, you know, epilepsy monitoring units are where people are admitted, hooked up to the EEG, and then they sit there and wait for seizures to come. And usually it's because we're trying to understand more about their epilepsy. Usually it's because we're trying to figure out if they can have surgery for their epilepsy, right? Cynthia,
Right.
you're in London, and there's a great epilepsy monitoring unit in London working very hard to identify surgical candidates for epilepsy. So there have been, not a lot, but there have been some deaths that have occurred, some SUDEP deaths that have occurred in people who were actually hooked up to the EEG. In those cases, everybody had a full seizure that was in the brain, and you could see it on the EEG, but also in the body. The thing about those cases are those people were a very specific type of person. So they weren't run-of-the-mill epilepsy, right? They weren't all different types. They were mainly people who were being evaluated for surgery, who were which means, they had drug-resistant seizures, and they had probably been weaned off their medicines to get them to have seizures in the EMU. So that is a kind of specific case, but that study did give us a lot of information about what we see in the brain prior to SUDEP in that setting. So could SUDEP be a silent seizure? It could be, but we don't really have a way of knowing that for sure.
Wow. You touched on monitors, baby monitors, and you know, co-sleeping. And a question here: my son has seizures in his sleep. What can I do to be alerted when they happen? So I guess the parents want to have a good night's sleep.
Of course.
And so, is there some sort of alarm?
Yeah. Well, Cynthia, you probably know about some of those seizure alarm devices. I bet you guys get a lot of questions about that too, right?
Yeah. So we could probably connect with.
So I mean,
on our
it's
website.
helpful to connect for sure, and there's lots of good resources online. But I mean, I think the question around seizure. So there's kind of two pieces to this question. One is, will seizure response devices, or seizure detection devices, I should say, reduce the risk of SUDEP? So just in general, it looks like, we don't have like super strong evidence for this, but it looks like if a person gets some attention after a seizure, if someone goes to a person after they've had a seizure, make sure they're in a safe position, make sure they're waking up from the seizure, and maybe give them a bit of stimulation. So like some rubbing, like rub on the back, that kind of thing. That probably reduces SUDEP risk somewhat, but the studies are not great quality in that area. And so we can't say that with great confidence. So the role of a device, if it was going to help, would be that then you would know when the child or adult had a seizure, and someone would be available to go to them, be with them, check on them. Okay. So in that way, any device that you're comfortable with that's going to alert you to a seizure may reduce risk. On the flip side of that, and it's an important flip side, there's two negatives. One is that people may get a false sense of security in using a device, that the device will catch all seizures, and that just might not be fair. That might not be true. The other is if the device goes off all the time, even when people are not having seizures, then no one gets any sleep. And in fact, even we know that not getting good sleep makes you have more seizures. It also makes parents difficult to care for, care for their children. So it's a very complicated issue. Usually I address this question, I get it all the time for sure. But it's very complicated. And usually I just tell people what I would tell that mom or dad if they were sitting in my office in my practice, is I would recommend to use a baby device, a bit like a baby monitor, because then now I realize that depends on you hearing when your child has a seizure. I do think that as parents, most of us sleep with one ear open. At least one of the parents does. I won't comment on which one, but at least one of the parents sleeps with one ear open while they're asleep, and that they will hear it if their child has a seizure. But again, it's not going to capture like a silent seizure like the other parent asked about, and it's not going to capture those deaths that aren't associated with the seizure. So I'm sorry I don't have a perfect answer to that.
That's a good answer. For the information that we have is what you're going to be able to relay. Can this happen to someone who's seizure free? but on medication.
Yeah, it can. And when it does, that's incredibly devastating. I don't know if you've had an experience like that, Cynthia, but I haven't. It's very heartbreaking because we know people have been doing their very best to have their seizures controlled. I think that's the rarest of cases. Very, very rare.
Yeah. And you answered this before, but you can reiterate, is a more heavily medicated person more susceptible? And I think you answered that, or you were saying reducing your seizures is the main thing. So it doesn't matter how many meds you're on, is that
exactly? Yeah, and actually those studies are really good. And they looked in like thousands of people. They even looked at specific drugs. Like, so you have to be careful because, you know, the internet doesn't like lose old data. So if you Google something, you might find something from, you know, 19 whatever from like 2005 that has now been refuted. So it will still say that, you know, one drug looked like it was associated, but now they've kind of changed, you know, now that's been refuted. So no specific drug is associated with SUDEP.
Right. And as long, yeah. Here we go with the heart rate question. So the heart rate drops below 45 BPM some nights. Seizures occur at night mostly. Is this a risk factor?
Yeah, so heart rate dropping below 45 is not necessarily dangerous. It's hard when I don't know who I'm talking to and I don't know the age of the person and I'm not their doctor and I don't know their general health. I mean, some very healthy runners have heart rates that go below 45 while they're sleeping, you know, just because they're super healthy, right? So that would be something specific. I'm sorry, but I think they have to talk to their own doctor about that. So just having a heart rate that dips while at sleep is not a concern in and of itself.
Okay, good. Just going through the chat box here.
Sure. Oh, I guess I can look at the chats too. I didn't think of that.
So, okay, many of our clients ask questions about potential wearables for seizure detection and whether or not this would be beneficial when you're in a high-risk SUDEP category. Can you touch upon this? And I guess there are several different companies that have come up with.
Yeah, so like the watches. Yeah.
Mm-hmm.
So I know families that seem to like using those. Cynthia, do you know families that use those and find them helpful? I think it's about the false positives, and false positive means it goes off and it's not really a seizure. And so if you can manage to get the device to have a setting that really is specific to your child's seizures or to the person's seizures, then I think people, it does seem to give people peace of mind. I mean, I don't think in any way, there's no data to suggest it's going to reduce the risk of death, but if it's going to alert you when the person has a seizure, then I recognize that can be helpful. You know, they think about it when you go to look at those. If you're in the market for one, think about what they monitor and think about whether what that device monitors is something that's relevant to your person's seizures. So some of them monitor heart rate, some of them monitor movement. They're called accelerometers, and they measure the shaking. There are video things that you don't wear it, but that, you know, you can set up a video camera that kind of like a Wii or what, you know, the video game consoles can monitor movement and it can pick it up when a person is shaking with a seizure. There are mattress sensors. You kind of have to tailor that to the person's epilepsy.
Yeah, and sometimes we link families together because families become familiar with these devices and then they can help other families and share their experience with that. But the two things are the false positives and the false sense of security. You just don't want to rely too much.
So you hear that too. Yeah. I mean, one thing we haven't talked about that I think is a good idea, and I should put it in there, is it's reasonable for people living with people with epilepsy to have good first aid training. I'm sure they can contact your office for how to get that, either local to them or whatever. So there's first aid for seizures and there's first aid in general, and there's basic CPR training. Again, we need to make sure that people understand that that's not necessarily something that's going to help for sure. But I think we should all have that, really.
glad you brought that up, because we do go out to schools, family groups. We've conducted them in the office with extended families so that everyone knows how to handle a seizure. And we have we do the clinic to community program. So we're in the physician's clinic and being referred right upon diagnosis. So those families learn right away when a seizure is and is not an emergency, and they learn how to deal with it responsibly and safely, and not have to resort to their to the EMS and all of that routine, because we all know what that's like, and especially now we don't want to go there unnecessarily. And so we will come to your place of business, to your school, and as I said, we will host family groups, and then we link the families together as well, so they can have support with each other. So that's a good point. The seizure first aid, and in the clinic to community program, we always address the SUDEP. Maybe not the first visit, but some of the families, it's a lot of information. It's overwhelming at first, but we do take that responsibility.
Thank you. That's good to hear. I appreciate that. I love that program. That's a great program, the clinic to community program.
Just looking at the chat box. Somebody joined late, so I know this was covered, but you can recap. Is this mainly a risk for younger people or adults at the same risk?
Yeah, so it's a good question. We talked about that a little bit at the beginning. People used to think that kids were at a lower risk, and that the highest risk category was kind of young adults, so like 20 to 40 or 20 to 50 years of age. But now I think we pretty much believe that the low risk in children and the low risk in the kind of older, kind of elderly group was just related to the fact that we weren't kind of finding those groups in our studies. And now we really believe that the risk is pretty much the same throughout life at around 1 in 1,000 people per year.
Right. And a stat, someone's asking the day versus night stat, which concerning SUDEP, which you also can maybe just
again, most of the deaths do happen at night or from sleep. It could be also from a nap, potentially, if a person was taking not a little cat nap, but like a substantial nap through the day.
Once someone's drug refractory, you look for other means. So you advocate for the diet, the ketogenic diet. And someone's asking about for the dog therapy dogs, or the Dog Guides of Canada have seizure response dogs. Do you have thoughts on that?
Yeah, well, you know what? I participated in a debate about this topic at one of the medical conferences. Sometimes at those conferences, they like to do things like in a debate format or something, just to make it like a more interesting kind of way of talking about the topic. But it did give me the opportunity to kind of review what's available as far as information to suggest that seizure response dogs would keep a person safe from SUDEP. And I don't think there's any, suggestion from the medical literature that seizure response dog is going to reduce a risk of SUDEP. It's possible that if a dog is well trained, that they can act like a seizure detection device and alert other people in the home through barking, so that somebody can come and help to keep them safe. I know people have some very positive experiences with seizure response dogs, so I'm absolutely in favor of that. But when we look specifically at reducing risk of death, I don't have a lot of evidence for that.
I think our clients who've had the dogs really feel that they help with their mental health. They help with their keeping calm, they've got a companion, they've got, and they're just animals in general are comforting.
Yeah, well, I have a dog and I understand that as well. Yeah.
So one final question. What is your message to parents or people who are scared to talk about SUDEP?
Well, my message, so it's interesting. I talked to doctors who were scared to talk about SUDEP. I don't know, are they scared? They're definitely reluctant. And my argument there, so obviously, like you've heard me talk, and I'm obviously a proponent of talking about it. So I feel my role is to try and convince them that it's okay to talk about SUDEP. What's my argument there? First of all, I think that as I showed on like my second slide or something, there's really good evidence that people want to know about SUDEP, that people living with epilepsy and the people caring for people with epilepsy, people in their families, they want to know about this. And so they will go seek information. And I hope that as the doctor partnering with families to treat children with epilepsy, that I am a good, reliable source of information for those families. I hope I'm among their best source of information. Just like Cynthia, you guys are among their best source of information. And you and I, we're the people we want them to get the information from. We don't want them
Right.
going Googling and looking stuff up that doesn't make any sense. So one of my arguments is that your healthcare provider and your advocacy organization, those are the groups with the reliable information, and those are where you want to get your information. So that's one reason. And we know people want to know about it. The other thing is to think about why people are scared to talk about it. I can tell you that there has been some studies also looking at whether there is a change in anxiety or kind of problematic behaviors in people who have learned about SUDEP, and there isn't. Because as much as the discussion can be scary, it actually can also be reassuring. When I talk about the elephant in the room, you know, like I did at the beginning of the talk, and I said, like, often this isn't the elephant in the room. Families are scared to ask me, could my child die of a seizure? And most of the time, and if I think they want to ask and they don't ask, and I bring it up, I say exactly that. I say, you know, a lot of families worry when they see their child have a seizure that they could die. Is that something you're worried about? I'd like to talk to you about that. And then I say, actually, I think the risk for your child, I mean, if it's true, I say, I think the risk for your child is actually quite small. And so sometimes the conversation can be reassuring. So just like lots of scary things that we don't want to talk about, sometimes what we imagine is worse than what the reality is. The other thing is
power.
being, yeah, that's what I was going to say, being empowered to do something about it. I guess that's my best answer to that.
Wow, that's, you know, an amazing presentation, so informative.
Thank you.
Stay with us for a minute. I'm just going to mention to everyone that May 21st at 11 a.m. we're talking to Dr. Elizabeth Kerr, and she will talk about comorbidities of epilepsy. So that'll be another really interesting hour. And thank everyone for joining us. And we'll see you on May 21st.
Wonderful. Thank you so much, Cynthia, for having me today.